So is chemotherapy dead? I think largely it is in CLL. I think there are some patients, perhaps those very favorable mutated patients, we can still think about FCR because of that potential for that long-term survival advantage. But right now, I'm not sure that even those patients will be very prevalent. You have to be younger, you have to be able to tolerate the regimen. We'll see how that plays out over a little bit more time. We still worry, of course, about the most aggressive patients, and for some reason, we are not getting enough FISH studies done to look for 17p deletions. That needs to be done very frequently and routinely. And when we see those patients, they're not candidates for chemoimmunotherapy. We should be really thinking about targeted therapies for those patients.
So I mean, I agree with you on the need to get all those prognostic factors, and I routinely get it in my patients, including the FISH and next generation sequencing and, of course, mutational status. But you can make an argument, right, that if all roads lead to ibrutinib, why bother? Brad, what are your thoughts?
I think it's an interesting conversation to have with a newly diagnosed patient, particularly the mutated patients. We heard from Matt that the results comparing ibrutinib to the different chemotherapy regimens, the outcomes look roughly equivalent for progression-free survival if you limit the analysis to the mutated patients. So if I have a young, healthy patient who is mutated, I will still offer them the option of FCR, and I'll go through the whole discussion about what that would look like relative to doing ibrutinib as frontline therapy. And if I have an older patient who's suitable for BR, I'll go through that whole discussion with them about what BR would look like relative to doing ibrutinib. And it's an interesting discussion of pros and cons. Time-limited therapy, yet it's chemotherapy versus just taking an oral targeted agent, but that's indefinite therapy. And because the outcomes look roughly equivalent for the mutated patients, I let the patient kind of guide me. And if I have a patient who says, I definitely want to do the oral agent, I'm fine with that. And if I have a patient who says, I'd rather do the time-limited option, whether it be BR, FCR, I'm fine with that. So I think either option remains appropriate for the mutated patients. If the patients are unmutated, or if they're 17p, then I will steer them toward a targeted agent rather than chemoimmunotherapy.
I have to say it's been a while since I put those options out to a patient. I said, you can get chemotherapy for 6 months or you can stay on the pill. Everyone in my practice always says they want to take the pill. I realize that, and even when you lay out the potential adverse events of being on ibrutinib or other BTK inhibitor for a while. But Matt, do you think, I think a lot of studies have shown that outcomes are substantially better in the 17p deleted patients with ibrutinib now in frontline. That said, they're probably not quite the same as they are in other subgroups. Is that reason enough to want to check for 17p deletions? And do you think that's enough? Do we need to be doing next generation sequencing to look at mutations in that gene?
Yeah, absolutely. So I think testing for 17p deletion is still relevant, both from a prognostic standpoint, but also still can influence our long-term treatment approach, particularly for younger, fit patients, because we know that ibrutinib only has modest durability in terms of the response for patients who have deletion 17p. We have some evolving data that we've seen now of 5 years from the NCI group that studied this in a small number, I think 34 patients with deletion 17p in the frontline setting, and about 3/4 of those patients were still in remission at 5 years. So that does look promising, especially compared to the relapsed refractory data, where we only see about a 2 to 3 year PFS with ibrutinib and 17p. But if we have younger CLL patients in their 50s or early 60s who are fit, these are not great numbers, and we need to still be thinking about the next step. And for some of these patients, this could involve cellular therapies. We have CAR T-cell trials now in CLL. We still have allogeneic transplantation, which is a potentially curative therapy. It's not something we're using widely right now in CLL, but I think that as we use ibrutinib in the frontline setting, and then we might use other agents like venetoclax, these younger patients may run into difficulties down the line. So it's something we might want to start planning for if we know about that 17p status. In terms of the question of mutational screening, also, I think it is helpful to look for TP53 mutation. We know that these patients have a similar outcome as 17p deleted patients, and they should be steered toward novel agent-based approaches, even if they have mutated IGHV.
John, are you routinely getting on the front line for all your patients? Are you routinely getting all these prognostic factors? I mean, I've heard some people say, well, you're 80-year-old, does it really matter? It's expensive to get all this testing done. What do you think?
Well, I think it's true that not all 17p deletions are created equal, right? So there are some that will behave in a very indolent fashion. And, it is also accurate to say that, you kind of know who these people are in the relapse setting based on their prior therapies, how well they've done, what their durations of remission have been like. You can kind of often predict if they're going to have a very high-risk feature or not. That's a little less helpful in the frontline setting where you don't have any of that information to guide you. I think it's always important, though, to know what the genetic features are of a patient's disease at every time you're thinking about treating them. I highly recommend doing a FISH test, pretty much in every patient at the time you're trying to treat them. It does help for planning. I think that was very important to point out. But again, also it'll help with understanding the right treatment for each individual patient. Patients not only with 17p are high risk, but patients with 11q deletions are high risk as well, and we need to know about those patients. They do better, it seems, in general, with BTK inhibition compared to chemoimmunotherapy. Those are the people that tend to have bulky disease, so we might be thinking about getting CT scans in those patients where we might not otherwise if they do, again, have an 11q deletion. I think for sequencing in patients, I think there's still not a wide need for that outside of looking for TP53, but assessing for Notch1 or some of the other high-risk features isn't particularly relevant right now, maybe because it's not directing our therapy. But it is important to know in younger patients, perhaps, again, for planning if you're going to do a cellular therapy or not.
So I think John brought up an interesting point that all 17p patients aren't the same. Do you think it matters whether the relative frequency, the loss of, there's people who have just above the lower limit of normal of cutoffs, and there's people who have 60% of their cells. I mean, does that change the way you think of the patient?
It does, yeah, I fully agree with that. So a lot of labs, including our own, uses 5% as a cutoff for deletion 17p. So we'll see these cases that have 6, 7%, and they're technically deletion 17p, but they don't tend to behave like an aggressive 17p at that threshold. Usually we start to see more aggressive disease that gets closer to 20% or higher. That's when we're more concerned. We're more concerned when we see deletion 17p in the context of a TP53 mutation at the same time. And then there is this subset of patients who have mutated IGHV with low-level deletion 17p who can have a very indolent prognosis and stay on observation for several years.